So now we'll switch over to try to look at some of the imaging findings of a normal mature fistula and compare that to some abnormalities. In the artery, which is 2 centimeters cranial to the anastomosis, in this case we see arterial waveforms with peak systolic velocity of 215 centimeters per second. We'll use this to compare to the anastomosis, which is 260 centimeters per second. So there's no gradient between the two. Notice that the artery has a nice black window showing that this is fairly laminar flow without turbulence or aliasing. The draining vein at the anastomosis has a slightly small diameter, 2.7 millimeters, but as you get into the draining vein in the caudal forearm, it rapidly dilates up to a usable fistula diameter of greater than 4 millimeters, in this case 7.4 millimeters. Also notice that the depth to the skin is very small, less than 5 millimeters deep. Looking at the volumetric flow, we are over 500 milliliters per minute, as shown here, 524. So this would be something that we would call a sonographically mature fistula. Always we try to look at the artery distal to the anastomosis to see whether or not there is still flow going to the hand. And in this case, you'll notice even though we are below the anastomotic site, the flow is coming toward the transducer, which is toward the patient's head. So there's reversal of the distal arterial flow in this example. Now comparing this patient to an immature fistula, the diameter of this fistula is 2.9 millimeters, so less than the 4 millimeter cutoff. It is not too deep, but notice when we look at the volumetric flow, we only have a volume flow of 267 milliliters per minute. So when I try to show you that we can call a fistula mature or immature by ultrasound, the next question should come up, well, how does this correlate to the actual clinical access of the fistula? If we are saying it's sonographically mature, does this predict whether or not the patient's fistula can be used for dialysis? So to this end, we evaluated 95 patients who, on clinical palpation by a trained nurse, were deemed to be clinically immature. We wanted to see whether or not ultrasound would be of benefit in these patients. In this group, 29%, so nearly a third, actually were mature by sonographic criteria. And in these patients, 91% were subsequently usable for dialysis by the hemodialysis nurses. In the 71% that were sonographically immature, patients who refused to undergo salvage only had a 31% usable rate, whereas the patients who underwent salvage of an abnormality such as correction of stenosis or ligation of competing veins, 78% eventually were able to dialyze with the fistula. So what was the variety of abnormalities that we saw in these patients that were clinically immature and then also sonographically immature? Stenosis was present in about a third of patients, and then nearly a half, or approximately a half, had a competing branch within the first 10 centimeters. And then about a third were too deep, which can be helped with superficialization. If you notice, these numbers do not add up to 100% because some patients had multiple lesions. When we're evaluating the different types of abnormalities, stenosis is the one that is most commonly brought to mind. For stenosis, the anastomosis is the most common site that it occurs. We've shown previously that if there is a ratio of the anastomosis to the feeding artery 2 centimeters proximally, a ratio greater than 3.0 suggests a 50% stenosis. So you need to really pay close attention to the anastomotic region. And this includes, 2 to 4 centimeters of the feeding artery and the first 2 to 4 centimeters of the draining vein. This is the sort of most common area to look for stenosis. Now, if you find a stenosis, don't panic. You still need to look at the rest of the exam because there could be multiple lesions and if this patient's going for a salvage procedure, they would want to correct them all at the same time. This is an example of a fistula with an anastomotic stenosis. Notice that there is turbulent, disorganized flow in the anastomotic region. When you look at the feeding artery 2 centimeters from the anastomosis, we have a peak systolic velocity of 123. At the anastomosis, notice this very turbulent flow, loss of the black window underneath the waveform, and a peak systolic velocity of 593 centimeters per second. So this is greater than a 3-to-1 ratio, and this would be suggestive of anastomotic stenosis. When we move to the draining vein, we do not use the 3-to-1 ratio for 50%, but instead the criteria have suggested that a 2-to-1 ratio is consistent with a 50% stenosis. For a 3-to-1 ratio, it was more suggestive of a severe stenosis greater than 75%. When you see dilated veins in the draining vein, look to see whether they're very tortuous, look to see whether there's a good flow volume. The reason being, if you have a draining vein stenosis, the veins will often try to bypass this stenosis through collateral vessels. So you could be seeing a high pressure collateral trying to bypass the stenosis, and you'd want to try to pick this up. This is an example of a draining vein stenosis. Again, the anastomotic region looks pretty good, 51 centimeters per second. As we look at the anastomosis, there is some turbulence and aliasing, but no gross significant stenosis. Then we look at the artery 2 centimeters cranial to the anastomosis, and this really has no ratio between the feeding artery and the anastomosis. However, as we start following the vessel out, and this is in a longitudinal view, 5 centimeters from the anastomosis, we start seeing thickening and irregularity of the draining vein. So what would we do next? We'd put color on. We see that the vein is patent, however there is some narrowing and irregularity. And when we put a velocity gate on this region, the peak systolic velocity is over 200 centimeters per second. So what would we do next? We would look 2 centimeters upstream from this level, and we see that the peak systolic velocity is only 40. So this gives us a 5-to-1 ratio. So this is easily consistent with a draining vein stenosis. And in this case, just to confirm, we give the volumetric flow measurement, which shows a volume flow of 177 milliliters per minute. So again, an additional criteria that this is not clinically or sonographically mature. Sometimes we like, when it's a long segment stenosis such as this, we'll use an extended field of view just to show the length of the abnormality, which I think shows nicely in this image. Now, draining vein stenosis should be differentiated from draining vein occlusion, as we see here. When you have echogenic material filling the draining vein, this is a good hint. You do compression, it won't compress, and then if you put a spectral gate on, you may get some artifact, but really no adequate flow. And then this is just a nice video clip showing the pulsatility of the clot as it's being sort of pushed upon by the vascular flow. When you see draining vein thrombosis, or when you see anything that causes a low volumetric flow, if you haven't identified a proximal abnormality, meaning an inflow or anastomotic or proximal draining vein stenosis or thrombosis, then you should start moving farther along the flow toward the central venous system. Typically we will follow the draining vein up the arm and go to the subclavian vein and then try to infer central flow of the brachiocephalic veins with our spectral Doppler. In an arterial graft, the large volumes of flow that may be there may overwhelm the central venous phasicity. However, in hemodialysis fistulas, you would typically expect, even with the increased flow, that the venous waveform here should go back to the baseline, and sometimes we'll have transient reversal of flow. In this case, you can see this is very monophasic flow, worrisome for central occlusion or stenosis. We then look at the left subclavian vein and a very similar appearance. Monophasic flow, no return to the baseline. This is worrisome for a central occlusion. If you have the ability to do a MRV, then you can try to evaluate the central veins. This has become more problematic in recent years because the diagnosis of nephrogenic systemic fibrosis in patients who receive MRI gadolinium contrast with renal failure. Since most of these hemodialysis patients are in renal failure, there's a likelihood that these patients would not be able to get a gadolinium enhanced MRV in these current days. But you can see here on this image at least, there is a long segment occlusion of the left brachiocephalic vein, and also no flow is visualized in the right brachiocephalic vein.